All right, we're going to do chapter 9, which are labor and birth processes. We're going to talk first about factors that affect labor, and then we're going to talk a little bit more about the birth processes themselves. We have categorized the different factors, or at least 5 of the factors that affect labor, by saying they're the 5 P's. The first of the P is the passenger. This is what is going to come out in labor. The fetus and the placenta. That is what labor produces, what we deliver. The passageway is the birth canal. That's where the fetus and the placenta will exit through. The powers are the contractions, and we'll talk about how those are broken down into primary and secondary powers. And then the position of mother. We have talked about how important it is for her to be in a good position. Squatting opens up the pelvis about 2 centimeters to help the baby rotate and get down. And then the psychological response. How is mom handling the whole labor and delivery process? If she is stressed out, if she is tense, if she is anxious, if she is fighting, she is not going to be able to handle how difficult this is. I mean, they call it labor for a reason. It's hard work. So her psychological response is going to have a direct impact on how that labor progresses. So let's take the first P, our passenger. What do we have to think out? Well, first of all, how big is the head? We know that the head's coming through. Think about a fetal head compared to your head. Yours is a solid skull. Well, the fetal head is very unique in how it allows delivery. The bones are not fused together. Therefore, you can get something called molding, molding, which allows the skull bones to shift and slightly overlap, and that will produce that typical cone head that you may have heard about with babies, how they have the little point at the back of the head, because that helps give almost a bullet shape to being able to deliver the head through the passageway. In looking at the diameters, there are different diameters that are measured. Ones I want you to be aware of, the biparietal diameter, that is a large transverse diameter, and if you ever read ultrasound reports or hear people talk about measurements of the fetal head, they use the biparietal diameter because it's really an important indicator of just how big the head is going to be. One that is going to be relevant to how the head is going to get through is your suboccipitobregmatic diameter. It is the smallest of the anterior-posterior diameters, and in complete flexion, this diameter allows the fetal head to get through the pelvis pretty easily. Sutures are actually where the bones of the skull will fuse together, the suture lines. So they're not connected yet, but if you look at page 269 in your text, you'll be able to see where they butt up against each other, and a delivering provider will actually be able to put their head in and be able to trace where those suture lines are, and that leads into the fontanelles. Fontanelles are something that we refer to as soft spots in the baby. The anterior fontanelle is larger than the posterior fontanelle. We'll get into the specifics of diameters when we're doing our newborn assessment later, but those are landmarks that the provider will be able to utilize to determine what orientation the fetal head is in. And then, as I said, the molding is the end result of those bones sliding together, having that slight overlap to result in that cone shape to be able to allow the fetal head to pass through the birth canal much easier. Presentation is what are we getting when the baby's coming out, okay? If it's cephalic, then it's going to be a head down, and that's what we want most of our presenting parts to be, the head. However, they don't always come out that way, and so breech is what we term whenever it's the buttocks down and the head is up. If our baby is in a frank breech position, then the buttocks are down and the legs are extended straight up towards the head. If they are in complete breech, then the baby is in its normal flex position. Its legs will be crossed at the knees, kind of tucked in, but instead of being head down, it's going to be head up. You have a footling breech, which is the baby is head up, and you have a single footling, which is one foot is coming out through the birth canal, or you can have a double footling. And then you have the shoulder presentation, which is where your fetus is actually going to be lying transverse or horizontal to the bony pelvis, and the presenting part is going to be the fetal shoulder. When we refer to fetal lie, what we are talking about is the relationship of the fetus's spine in relation to the maternal spine. So if the fetus is in a longitudinal lie, then the fetal spine and the maternal spine are parallel to each other. If they are in a transverse, oblique, or horizontal, then the fetal spine is going to be perpendicular or on an angle to the maternal spine. Now, attitude is not how sassy the fetus is. Attitude simply tells us what the fetal parts are in relation to one another. So think about your fetus and the pictures that you see whenever it's in utero. It's kind of curled in on itself. We all are familiar with the term fetal position. You've got your arms crossed over in front of you, your knees are drawn up, your ankles are crossed, your knees are flexed in. That is what we consistently look at as a normal position, general flexion, if you will, for the fetus. And then that curls in, it protects the insertion point of the umbilical cord. That is your characteristic fetal attitude. Positions are in relation to the occiput, the back of the head. Remember, that's the part that gives you the cone head, what's going to come out first. If it is occiput anterior, then that's the back of the head. The occiput is up against the symphysis pubis. So, in essence, the baby is looking towards the mother's back. If it is OP, the occiput is posterior, which means the back of the head is against the mother's spine, and then the face is looking up. Sometimes we'll refer to this as a sunny side up baby. Women who are in OP labors will actually have more back pain with their labor, because think about it, you've got the back of the baby's head coming against that lumbosacral part of the spine as the baby's coming down. When we're talking about station and engagement, station is where the fetal head is in relationship to the ischial spines in the bony pelvis. If you were to draw a line connecting the left side to the right side at the ischial spines, that would be 0. It's what I call the equator. Anything that is above the equator is going to be a minus number. So if you hear your fetus is at a -3 station, that fetus is still pretty high up in the uterus. It hasn't started descending down into the birth canal yet. As the baby drops and gets closer to those spines, those numbers go down. So you have a -3 station, a -2 station, a -1 station, and then you have 0 station. We are at the equator. Well, once the presenting part gets below the equator, then we're going to start counting into the positives. So when the presenting part is a centimeter below the ischial spines, then we are at +1. It goes down +2, +3, and delivery is said to be about to happen when what we classify the presenting part as a +4 to a +5. I generally say when we're +5, we're in the bed. So the station of the presenting part needs to be determined when labor begins so that we can determine the rate of descent, because for every number that you go down, that's a centimeter of descent of the presenting part through the birth canal. We say the fetal head has quote unquote engaged once the largest diameter, usually the biparietal diameter, passes through the maternal pelvic brim or inlet and comes down into our true pelvis. And the book says that this generally correlates to zero station. And so you were wondering, why do I have placenta here? Well, how would the placenta affect labor? Maybe the position. If we have a low-lying placenta, could it get in the way? Could it cause some issues with fetal descent? Or what about just a full-blown placenta previa where the placenta is actually covering up the opening, the os, and the fetus can't get out? So things that can affect labor, yes, the fetus definitely, but also you got to remember that placenta and what part does it play into everything. When we're talking about the passageway, we're going to break it down into two different sections. You've got your bony pelvis, and then you've got your soft tissues like your pelvic floor musculature, the vagina, the cervix, that kind of stuff. So the first thing we're going to talk about is the bony pelvis of the passageway. There are 4 different joints that are fused together to create the pelvis. You have your ilium, your ischium, your pubis, and your sacral bones. When we fuse all those together, you get a right and left sacroiliac joint. You get a symphysis pubis, which is in the front there. It feels like a bone, but it's actually the fusion, and that symphysis pubis is fused and has that cartilage there. A lot of women, especially late in their pregnancy, will get very tender and uncomfortable over that area. And I've actually had women who have strained that joint and during the birthing process have actually fractured into that joint. Then you have the SC, which is the sacrococcygeal joint, which is towards the posterior. So all of those joints come together and then they create your pelvis. Your pelvis is separated into a true and a false pelvis. Now the false pelvis is above the brim, really doesn't have a whole lot to do with the birth process. It just creates kind of like that little supportive cage for the fetus. It's the true pelvis that is involved with birth, and we have 3 different levels, if you will, of the true pelvis. We have the inlet, we have the midplane, and we have the outlet. Now the inlet is referred to as the brim, mid-pelvis is our cavity, and then the outlet is where the baby's going to come out and start getting into the soft tissue, into that passageway. One thing that I want y'all to be aware of is the suprapubic angle. This is going to be very, very important because the fetus has to pass beneath the pubic arch, which is a pretty tight little space. If it is a narrow angle, then we're going to have more difficulty to get that fetus through. For the few of y'all who have actually come through labor and delivery clinicals, we've talked about a shoulder dystocia, or how, the anterior shoulder is up and that baby has got to pass underneath that suprapubic arch to be able to get out. So that is an important thing to take into account too. But overall, just the shape of the pelvis itself can be a direct factor in what we anticipate labor to be like. Now, there are 4 basic shapes of pelvis that we look at. We have the gynecoid, which is just our pretty classic female shape. That is what we hope whenever the provider assesses the pelvis that they are going to declare it to be. Now, your android is going to be more of a male-shaped pelvis. You hear about, grandmas say, oh, those are childbearing hips, or you got man hips. How wide does the pelvis look, or is it a slim-hipped kind of thing? The anthropoid is a pelvis that resembles the anthropoid apes, and then your platyploid is a flat pelvis. Thankfully, there are not many people out there with that type of pelvis. Your gynecoid, which is the female pelvis, is most common, and major gynecoid pelvises present in 50% of all women, which is a pretty good statistic to say, okay, half the women having babies should have an appropriate size pelvis for this fetus to come through. Okay, so now we're going to look at the soft tissue. Picture, if you will, your uterus, okay, that kind of upside down pear shape. So the top of it, the body of the uterus, that's that thicker muscular piece that's going to be responsible for contracting. Then as you're coming down and getting more towards the neck, you have the lower uterine segment. This is kind of a static piece in that it's not contracting. It is going to stretch and elongate as the upper uterus contracts, pushes the baby down. Then the lower uterine segment is going to stretch with the labor and the descent. We'll talk about it in later chapters, but that lower uterine segment and how long a fetus sits in it before it actually pushes on out has a lot to do with a mother's risk for hemorrhage after she's had the baby. Well, the cervix is what the baby has to come through, right? And remember that when we're talking about cervical thinning, you have dilation and effacement. Well, to be completely gone, which the cervix has to do, it has to be 100% effaced. So that means that whole cervix piece, okay, has got to completely thin out and disappear. It has to open up from being completely closed to 10 centimeters. So for a woman to be able to effectively have her baby, the cervix has to be completely gone, open up 10 centimeters, and effaced 100%. Now the pelvic floor muscles are going to be utilized by the mom with her contractions, and it's going to help the fetus rotate during delivery. It doesn't just come down a chute in one position. There are actually what we call cardinal movements that the fetus will have to go through to be able to deliver easily, for lack of a better word, and make sure that nothing gets hung up in there. The vagina will dilate during delivery. I mean, you got to think about your cervix is opening up 10 centimeters. You're pushing a pretty big object down through there. If the vagina did not change as well during the whole birth process, that baby's not going to come out. And then the final piece of the soft tissue is the introitus, which is simply the exit of the vagina. That's where we're going to see the presenting part, the fetal head. We're going to see the crowning and everything as we're coming through there. Okay, so how does the fetus get down to get out? Well, it's the powers of the delivery process. And we break powers down into two areas. You have your primary powers and your secondary. Primary are the involuntary contractions, the ones that just happen when a woman goes into labor. She doesn't need anything to make that occur. It is the body's natural endogenous oxytocin effect making the uterus contract. So with the primary powers, the involuntary contractions, as with anything, we're going to be watching the frequency and the duration of the contractions. Now, if labor seems to be slowing down or stalling, yes, there are things that we can do to augment and help the labor along. But for the most part, the endogenous oxytocin that is delivered by the mom and the fetus once active labor has been reached and established will be enough to push the labor along. Having those involuntary contractions also have a direct correlation and impact to effacement and dilation. If a woman is having contractions, but she is not making cervical change, she is not in labor. So can she have contractions but not be making cervical change? Yes, that is not labor. Labor is defined with the contractions and having cervical cervical change as a result of those contractions. Okay, so as the primary powers, the natural contractions that the uterus is undergoing, as they are pushing that baby down, okay, and then we finally get the head down to the point that it is at the cervix, okay, and it's pushing through. When that head gets down, stretch receptors in the posterior vaginal wall will cause another surge of endogenous oxytocin. So you've got your active labor, you've got mom is putting out 3 to 5 milliunits of oxytocin, baby is putting out 2 to 3 milliunits of oxytocin. So you have that pushing through. Then once we get that head down through that lower uterine segment, through the cervix, at the vagina, when that head hits again, we have something called Ferguson's reflex, which is when you have a second endogenous oxytocin release. Ferguson's reflex is a trigger sort of to mom that says, okay, I want you to push now. So you may hear women say, I feel like I gotta push, I need to push. That's a response to Ferguson's reflex. So the secondary powers are when mom gets involved and mom starts pushing, okay? So there are different ways that women are guided to push. Valsalva pushing or closed glottis pushing is not recommended. Unfortunately, that is what many of them do, especially in this area. It's where you take a deep breath in, you hold it, and you bear down. But when you Valsalva, you cut off circulation and oxygenation, you increase intracranial pressure in the mom, cardiac output is stopped. It is not a good pushing mechanism. So really we need to guide mom through her bearing down efforts and her pushing, and we need to use something called open glottis pushing when we are coaching mom, and we'll talk about that a little bit later on. Women are not supposed to have babies laying on their back. Okay, that is just not a natural position. Think back to medieval times, ancient times, heck, even current times in other countries. Women, a lot of times, will have babies upright. They'll be in a birthing chair or they may just squat or something. The position of the laboring woman and then how she delivers is going to have a direct impact on how the labor progresses, how that fetus is rotating to get into the correct position, how we're going to be able to get the fetus out. Is the mother going to be able to tolerate it? Is the labor going to go quickly? So the position that she is in while she's laboring is going to be very, very important. Well, in today's society, most women have epidurals, which means they can't change positions themselves, so we're going to need to help them change positions. It can be something as simple as rotating them from one side to the other. It can be sitting them up in bed. It can be helping them sit Indian style, sitting up with their legs crossed and let gravity help bring the baby down. But regardless, changing positions frequently, and by frequently I mean every 20 to 30 minutes, can have multiple positive effects on the labor. It helps relieve fatigue. And just think about if you sit in one place for too long without even realizing it, you're shifting in your chair or you are crossing and uncrossing your legs or something. It just helps relieve pressure on those tissues and on whatever that pressure point area is. So it's going to do the same thing for your mom. It's going to increase circulation to the area because if you hold pressure on a place for too long, well, we all know that, okay, that place, quote, goes to sleep because circulation's diminished. So by increasing circulation through position changes, you're going to help the mom tolerate and progress through the labor a little bit better. If she can move on her own, then different positions, it doesn't have to be drastic. It can go from laying on your side to sitting up. It can go from sitting up to standing. It can go from standing to sitting in a chair and just rocking. You can just hold onto a table and sway side to side. I've even seen people like slow dancing or something. Heck, y'all seen the viral videos out on Facebook and YouTube where people will actually be dancing. Anything that you can do to change position is going to help facilitate the fetal descent, fetal rotation, and it's going to help the labor progress. So we've talked about things that can affect labor. Let's switch over to the actual process of labor. So what is labor? Well, it is getting the fetus, the placenta, membranes, everything that's in the uterus out, in essence, okay? There are a lot of different things that takes place in a woman's reproductive and other systems up until the point labor begins, trying to get the body ready for labor. Um, Something as simple as you'll hear people talk about being nauseous or having an upset stomach. We're trying to make sure nothing is in the GI tract if it's at all possible. So the body is kind of a very interesting, unique thing in that it will undergo certain changes in preparation for what the woman is going to have to do during the process of labor. So, how do you know if you're in labor? Well, there are things that a woman can look for that can signal labor coming, so to speak. It's not a guarantee. However, lightning or dropping is one of the first things. Now, that is simply when the fetus is, instead of being all the way up under the diaphragm, up under the breast, it starts dropping down into the pelvis. Women will recognize they can maybe breathe a little bit easier. They can take a deeper breath. They may have a little bit more of an appetite or an ability to eat a little bit more. And you got to think about why. Well, instead of the fetal buttocks being all the way up, kind of shortening the space of the stomach, or preventing the diaphragm from dropping, it's now lower into the pelvis, so they have more space there. The truth is that can start occurring at like 36 weeks. Well, do we want labor to start at 36 weeks? No. So it is a sign that's preceding labor that generally when you have that happen, you can theorize that you are weeks to days away from going into labor. Now, the bloody show is that brownish, reddish tinged mucus that is going to be passing through the cervix. The cervical plug, that thick mucus that is in the cervix, is going to get lost. There are some women who recognize losing the plug. There are some women who don't have a clue. I never knew when I lost my plug. I obviously had to at some point, but I didn't pay attention to that at all. And not everybody's going to see bloody show. It is just something that if you see it, and when you see that, it may be a little bit closer to the actual labor about to happen. Nesting, we've all heard of women who have to go and fold and refold baby clothes. When I was pregnant with Rachel, I would go in the nursery. I had the nursery finished probably by about 7.5 months into my pregnancy. But I would go in the nursery and I would just sit in my rocking chair and just be in the nursery. And then I would go to her changing table and I would make sure the diapers were stacked just right. I would check her clothes and make sure things were hung up or folded. It's that nesting instinct of getting everything ready. Frequency, we talked about in light of having to go to the bathroom a lot. Think about, like I said earlier, with the lightning or the dropping, how the fetus is now dropping down into the pelvis. Well, it's kind of a blessing and a curse because you can breathe a little bit easier. Okay, you can eat a little bit better, but now you have the weight of the fetus sitting on your bladder. So you're going to the bathroom what feels like truly every 5 minutes. About the time you get your bladder empty, you get yourself cleaned up and clothes pulled up, you may feel like you need to go TT again. So the frequency is going to increase. And then the Braxton Hicks contractions. They can be real, painful, felt, strong contractions. But as I said earlier, unless you're having cervical change associated with the uterine contractions, then it's false labor. So the Braxton Hicks, they can start as early as 5 months, but they start getting a little bit more frequent and a little bit more intense, maybe you're aware of them a little bit more as your body is getting ready for labor. So, onset of labor, okay? Really and truly, it's not one single thing that says, okay, it's coming. There are a lot of different things that are involved with it. And people aren't really sure exactly what the mechanism is. One theory I've heard is that the uterus has stretch receptors in it and that the fetus will grow. You have X amount of amniotic fluid. You're going to get to a certain stretch point, and then that's going to send a signal to the pituitary to start releasing hormones. Is it the fetus that is dropping down and getting heavier that actually triggers that we're going to start releasing oxytocin? There's not really a single factor that can be attributed to what causes the process of labor to begin. Normal, quote unquote, labor pretty much is viewed when you have a term pregnancy, a woman goes into labor, it's a low risk pregnancy, no complications for the mother, no complications for the fetus, and the entire process is generally completed within about 18 hours. Okay? When we look at labor, we have different stages, okay? It's broken down into 4 distinct categories: first stage, second stage, third stage, and fourth stage. Your first stage is your longest, and it really is the most variable. If a woman has had multiple babies, then you could expect she will have a shorter first stage than a woman who has not had any babies at all. Now, first stage is actually broken down into 3 phases. You have latent or early, you have active, and you have transition. As the labor progresses through stage 1, you go from no dilation and effacement all the way to complete dilation and effacement, so 10 centimeters, 100%. In your women who have never delivered before, your primips, this first stage could take up to 20 hours or even longer. Now, once we hit full dilation and effacement, okay, first stage is done and we enter into second stage. Second stage is, in essence, having the baby, okay? It is pushing the baby out and delivering. In your primips, this can take, on average, about 50 minutes. I have seen women push for 2 hours, and I have seen women push for 15 minutes. Generally, your multiparas are going to have a shorter second stage than your primiparas. Third stage is delivery of the placenta. Okay, so the baby is out and now we have the placenta. In essence, there's not really much of anything the woman has to do to complete third stage. She will still have contractions. Now, they won't be as intense as the labor contractions. They'll be more like really bad menstrual cramps. Maybe. But the uterus will continue to contract to expel the placenta. If the placenta isn't out in about 15 or 20 minutes, then the provider is going to start looking to see what's going on. Now, I said we give it up to 30 minutes, but typically by 15 or 20, they expect it to be out. And then your fourth stage is once everything is out and we hit into, in essence, recovery. So you have the 2 hours from the delivery of the placenta until postpartum begins. Now, technically, postpartum is after the baby, but you've got to have that recovery time. You got to think about this is a procedure, and the same as you would have a recovery from a surgical procedure, this is in essence a procedure that still needs the same kind of recovery. That's what that 2 hour time frame will give us. All right, I talked earlier about the 7 cardinal movements. These are the different positions, changes, movements that the fetus makes as it is getting ready to be delivered, coming through the birth canal. How is it going to get out, so to speak? The first thing we have to think about is, and they really come together, engagement and descent. In your primiparas, engagement may occur earlier than labor, because they've got stronger abdominal muscles, they're going to be able to help push that fetus head down and get it engaged in the pelvis earlier than your multiparas, who have looser, maybe more lax abdominal wall muscles, who don't have that strength to push the baby down. You also have 4 different things that work together to get the descent going. The pressure of the amniotic fluid in and of itself will help guide the fetus down. But imagine when you have a uterus that's contracting and that fundus is contracting, and it is putting pressure on the amniotic fluid, which is putting pressure on the fetus. So the uterus and the contractions themselves, but also in conjunction with the amniotic fluid, is helping to push the baby down. You have the pressure from the mom whenever she is pushing, the diaphragm, the abdominal muscles, all of those working together to help get that fetus down. And then the fetus itself is going to go through an extension, kind of straighten out a little bit to give it more of a cleaner line to descend down. Now, once we have engagement and descent, then we have to finish up because we're getting ready for birth. So one of the first, the next movement then is going to be flexion. What is flexing? Well, the fetal head. When it gets down to the soft tissue area, when we are hitting the cervix, the vagina, those pelvic floor muscles, then the baby's going to kind of tuck its chin to its chest, and it's going to start getting the back of the head, the occiput, as what is coming up. Once we get that flexion, we're going to get the internal rotation as our next. That is where you kind of have the face down and the back of the head up, and it's coming down, so you're going to have that cleaner bullet shape coming down through the birth canal. Then you're going to have extension. When the face is kind of at the perineum, then you kind of have your baby's head goes down and then it goes back up. And I wish y'all could see me right now, because I am actually sitting here as I'm talking, making these movements with my body. So we'll go over this in class a little bit. But we have that extension, and that is the fetal head being delivered. Then we have an external rotation where we're getting back to get our shoulders where we can be delivered, and then we have expulsion. So what I want you to do to help you prepare for lecture and for exam when it comes time is pay special attention to page 279 in your book, and make sure you have a good understanding of just what those 7 cardinal movements look like and what order they come in, to be able to ascertain if that fetus is going to have a normal progress out or not. So I've got it labeled out here for you to be able to see engagement and descent, as you know, the fetus is coming down getting ready for labor. Flexion, as we're tucking our chin into our chest. Internal rotation, so that we can make sure that we get that occiput, that posterior fontanelle, get that head ready for the molding as it comes through the birth canal. As my head is getting ready to deliver, instead of tucking my chin to my chest, now I have to extend and get my face out. Then I have my external rotation and reconstitution. So how is the fetus able to tolerate what's happening in labor? Okay, what kind of preparation, so to speak, has the fetus made all throughout to prepare it for the moment of delivery and taking its first breath? Well, we know first about the fetal heart rate. Okay, it's a little unique. You have a range of 110 to 160. Earlier in your pregnancy, it's going to be at the higher end, okay? I've even had women, when I've checked them early in like their first trimester, the fetal heart rate would be even at 170. Once you get an intact neurosystem developed in your fetus, and that's generally going to be at about 28 weeks gestation, you're going to have a functioning sympathetic and parasympathetic autonomic nervous system. Those 2 components together regulate your heart rate, so that by the time a fetus is at term, it is going to be on average a heart rate of 140. Now, you still have a range of 110 to 160. That anywhere in that range is considered normal for a fetal heart rate. Your fetal circulation is very unique, and that fetal circulation has kind of been working to get everything ready for the fetus to tolerate delivery. With your umbilical cord, remember you have an artery, two arteries and a vein, okay? So the fetal circulation is unique in that oxygenated blood comes from mom through the maternal artery, but to the fetus through the fetal vein, and then exits the fetus through fetal arteries, but goes back to the mom deoxygenated through the maternal vein. So remember how circulation with your fetus goes. Uteroplacental perfusion is key during the whole development process and gestation process to be able to set the fetus up to tolerate the stressors of labor. You got to think about when the uterus is contracting, there is no blood flow going into the uterus. Well, if there's no blood in the uterus, then there is no blood in those intervillous spaces. And if there's no blood in the intervillous spaces, then there is no oxygen that goes to the fetus. Okay? So, all throughout gestation, the fetus has been putting behind in what we call fetal reserve enough nutrient, oxygen, everything that it's going to take to tolerate the stress of labor itself. At term, in a normal pregnancy, normal developed gestated fetus, the fetus should have about twice as much in reserve as what it actually needs to tolerate labor. So that is something that the fetus has done all throughout gestation to prepare it for being able to go through hypoxia, so to speak, from not getting perfusion from the mom to the uterus to the placenta and then to the baby. In labor, respiratory movements of the fetus will decrease. And then you have the actual activities of labor. When the baby comes through the birth canal, you got to think about it. It's almost a CPR effect of the vaginal walls squeezing against the fetal chest. That helps clear all the lungs secretions out. You got to remember this baby has been, inhaling amniotic fluid in essence, okay? That has been in the lungs, so we have to get those secretions out. So that is one thing that helps get the baby ready to breathe. You have a drop in your PO2 and an increase in your PCO2. So that increased PCO2 is going to be a drive for once the baby's out and it has to breathe on its own, that increased CO2 is going to help trigger that need for that neonate to take its first breath in. Babies are respiratory driven. If they don't breathe, nothing else is going to work well. So the body has to go through certain adaptations to help get that neonate ready to take its first breath. So what kind of adaptations does your mom have? Well, cardiovascular wise, in especially second stage, her cardiac output with contractions is going to increase 30 to 50%. Now that's making sure that she's not doing closed glottis pushing Valsalva, because that's going to decrease her cardiac output, which is not good for her or for the baby. She's going to have an increase in her vital signs. This is labor, this is hard work, so her vital signs are going to reflect that. You can expect an elevation in the white count. That elevation is not an infectious process. It is in response to the stress, the inflammation that is what labor is. It's important that you know what other conditions your mom may have, though, because if she's had a prolonged rupture of membranes or another infectious process going on, she could have a secondary white count elevation from something like a chorioamnitis. So you have to be able to determine, is it an infectious or an inflammatory white count elevation. When she is laboring, she is going to have an increased oxygen demand because you've got muscles at work. She needs it for herself and for the fetus, but there's a fine line between breathing and hyperventilating. And whenever she is scared, when she's stressed, when she's in pain, she may want to breathe too fast, too shallow, the kind of breathing, which is not good for her or for the baby. So you're going to need to coach her through breathing to make sure that she is inhaling oxygen adequately and blowing off her CO2. She may experience a little bit of incontinence. That baby is sitting down low, sitting on the bladder with contractions. She may urinate, and that's okay. Having a little bit of protein in that urine, think about muscle breakdown, the tissue stress, and everything. You can expect a little bit of proteinuria. Somewhere about 1 plus is typically within normal limits. Other things to look at. For the skin, she may tear. If you have a very rapid descent and delivery, you can have vaginal wall lacerations, you can have introital lacerations, you can even have cervical lacerations from the baby coming through the cervix too fast. If the provider needs to open the delivery space, he or she may cut an episiotomy. Episiotomies aren't as common. They're not the first go-to like they used to be. They can either be a straight up and down vertical incision, or they can be at a 45 degree angle. Either way, it's cut down into the perineal space. But providers a lot of times are saying that it's actually better and you have an easier recovery and an easier heal time if the woman tears as opposed to being cut. We talked about how just the structural changes in the musculoskeletal systems in and of themselves as the woman's progressing through pregnancy are problematic, and you can have back pain, but you can still have the backaches even at labor just because of the laxity of the joints and not having that good structure and support. If you have a presentation that's OP, so the occiput is anterior and back on the LS space, then you may actually have an increase in the back pain. The suprapubic joint pain in the front where your pelvis is joined together, that's another point of discomfort. And the laxity in the joint should help for the fetal descent and the movement through labor, but depending on how much it is, you can still have discomfort at that point. A woman will, in labor, she'll be cold 1 minute, hot the next. There is no rhyme or reason to that. After she has the baby, she may just start shivering and shaking. Not necessarily will she feel cold, that is just the physiologic response that she is going through. If she has an unaugmented and uninduced labor, if it is natural oxytocin that puts her in labor and puts her through the delivery, natural oxytocin crosses the blood-brain barrier and will cause the release of endorphins for the mom. Pitocin does not. So women who have Pitocin labors may have less of the endorphin release, so they're going to feel more pain associated with their labor and their birth. GI changes, the body will go through changes to evacuate the GI tract. So you may have nausea, vomiting, and even diarrhea preceding the whole labor process to try and clean out the GI tract. And if that doesn't happen, it's not uncommon that in labor, the same way that a woman may have urinary incontinence, she may have bowel incontinence, or as the fetus is just descending down and the fetal head pushes over the rectal vault, if there's any stool in the rectum, that's going to pass during birth. And then finally, with the endocrine, you're going to have an increase in metabolism, obviously, because of the labor and the work, which is going to lead into a decrease in your blood glucose levels as a result of the labor that's going on. There is, a theory that says labor could be triggered by a decrease in progesterone, increasing levels of estrogen. You got to think about the placenta is responsible with the progesterone. Well, as the placenta is maturing and aging, if that level of progesterone drops off, is that what is going to influence the labor to start? And then the prostaglandins that we have, because remember the prostaglandins, the smooth muscle, the contractions, so all of those endocrine factors are working together, and those hormones, prostaglandins, oxytocin, estrogen, and progesterone, to get the labor initiated and to get the birth process started. All right, so that's chapter 9, the labor and birth processes. We talked about factors affecting labor, your 5 P's, your passenger, your passageway, the powers, primary and secondary, position of the mom, the psyche of mom, and how all of those different entities have an impact on labor and can affect labor process and going from start to finish. We also talked about the process of labor itself, the different stages. Remember, there's 4 stages of labor. Your first stage is broken down into 3 phases: latent phase, your active phase, and your transition phase. It is from 0 to complete as far as dilation and effacement goes. Your second stage is delivery of the baby. Your third stage is delivery of the placenta, and your fourth stage is the 2-hour period after delivery of the placenta, which is in essence a recovery time for the mom. Then we talked about just the adaptations that the fetus and the mom themselves make as they get ready for the whole labor and delivery process. So pay attention to the cardinal movements of your fetus. Pay attention to what levels of cervical change define each phase in stage 1, and the different things that affect labor, specifically the 5 P's, and how each one of those are defined. Bring any questions that you have about Chapter 9 to class, and I will see y'all Monday the 14th for our first test and Monday the 21st for our first class back.